Okay. Hi guys. Please could I just get someone to check that they can hear me? Cool. Thank you. All right. I'll share slides. Okay, and we've gone to the end of the. Ugh, sorry, one sec. Giving you all the answers. Okay, cool. Right. I hope you're all okay and that you're getting through term all right. It's nearly over, which is fun. Um, right. Can everyone see the slides? Can I get someone to put the thumbs up? Cool, thank you. All right, so today we're going to do skin and then breast and gynae, which both fall under the women's health umbrella. These are things that in your lab med aren't as high yield as some of the things that you did, for example, yesterday with the resp and the heme, but they do come up. And I felt that we really didn't get any proper teaching on it last year. And also, they're things that will continue to come up throughout fourth year with really no teaching on it at all until you do your women's health placement in fifth year. But you will have a breast exam to do, possibly in your OSCE, things like that. So it's just really, really good to know. And I find, and the skin stuff will come up in your lab med. So we'll start with skin. This is the syllabus for skin in lab med. As I said, I really didn't feel that we got much teaching on it. It was more kind of integrated into other topics I found. So it's good to just consolidate it all as one topic. So we'll start just with a really, really quick reminder of normal skin. I know that it's probably been a while since we all thought about this properly in preclinical. So just really quickly, we've got the epidermis, which is the uppermost layer of skin. Its most important function is as a physical barrier, and it's got this stratified squamous epithelium. So think scaly diseases because of the keratin. The dermis is the next layer, and it's this fibrous connective tissue with collagen and elastin. It's a bit more supportive. So with that, if something's going to go wrong, think blistering diseases. And then the subcutis is mainly fat, nerve, blood, and a classic pathology is erythema nodosum, which you might have heard throughout some of the other lectures. It comes up a lot. It happens in a lot of different diseases. If you're interested, I'd recommend you just look it up. But for now, it's just one of those things that will come up, especially in an OSCE. They'll say, oh, this patient has erythema nodosum. What do you think? This is the sites of the common lesions. Some things to notice are the viral wart. And remember that that in skin is caused by the HPV strains 9 and 11. That's different to the HPV strains, which we will come on to later, which are 16 and 18. Those are the ones that cause the cervical and gynae pathology, gynae warts, and then go on to cause cervical cancer if you're unlucky. So we'll start with the inflammatory skin conditions, and those are going to break down further into categories. So first, we've got the spongiotic disorders, and they're spongy because they're dermatitis involving the buildup of fluid in the skin. That's what makes it spongy, which for some reason I had a hard time realizing. And then those are the list of ones that will come up. Atopic dermatitis, eczema being by far the most common. And then you've got a variety of eczema-oid conditions, and then allergic contact and irritant contact dermatitis, which hopefully you'll remember from the immunology stuff that you've done. And then psoriasiform skin conditions are going to have these rete ridges on histology, and that's because these conditions are just so itchy. that people end up scratching them really hard and kind of almost causing their own scarring, which in turn makes it worse. And for that, you'll see these thick plaque-like lesions. If you ever see in a question stem the phrase kind of silver scaly lesions, think psoriasis. Next are the vesiculobullous conditions, which are exactly as it says on the tin, fluid-filled sacs. The two of those are pemphigus vulgaris and bullous pemphigoid, which you will have covered in lab med, and we'll just look at a table in a minute to remember the differences between those. And then we've got the interface conditions between the dermis and the epidermal layer, so the junction between those, most commonly erythema multiforme and Stevens-Johnson syndrome. Okay, so spongiform, as I said, you get this kind of bouncy skin from fluid underneath. You can see it's a bit small, but you can see under the word microscopy there's the different words describing the different features you'll get on histology in spongiotic dermatitis, and then what those things actually end up meaning. So hyperkeratosis is just scaliness. Hypergranulosis, you'll get this dark blue on histology. So if you hear that, then think this. I've already talked about the retiridges, and yeah. So we've got eczema, seborrheic dermatitis, which is the cause of dandruff, think scalp. It is essentially just eczema, but in the places that are very sebaceous, very oily, have a lot of sweat glands. Eczema, it's important to note, is most common on the flexor surfaces. So inside of the elbows, backs of the knees, all the little bits where your skin comes together, and that's important to think about in a minute. And then pompholyx, which is these vesicular kind of dermatitis, tiny little bits, and it can sometimes be confused with scabies, with the tiny little lumps in lines. So just think about that. As I said, hopefully you'll have already covered this. Allergic contact dermatitis and irritant contact dermatitis are different, although they sound very similar. The first is a type 4 delayed hypersensitivity reaction, which requires sensitization. It'll happen 48 to 72 hours after exposure. And the classic is a woman buys a new piece of jewelry, or a man buys a new belt, and then suddenly they have this real itchy rash exactly where the thing touched them. And that's how you know it's allergic contact dermatitis. And you'll get these really well demarcated areas of erythema. Irritant contact dermatitis is from direct physical damage over a long period of time. So most common if it comes along with an occupational history of working in close contact with chemicals, or maybe as a gardener working with different plants, that might be an issue, things like that. And yeah, can be caused by all sorts of things. Yeah. The psoriatic skin conditions are chronic and autoimmune. They normally present in teens and early adults, most commonly plaque, but can be in other forms as well. I've put erythrodermic psoriasis in red because that is an emergency, but luckily is very rare. And then the reason a minute ago I got you to think about flexor surfaces in eczema is because extensor surfaces are really important in psoriasis. So they'll be on the outside of your elbow, your kneecaps, things like that. They'll be silver, scaly, well demarcated. Might be associated with arthritis. So if you have this strange silver, scaly skin condition with joint pain as well, then that would still be psoriasis. And you might also see nail pitting on examination, but that's small print. Hopefully you'll remember these as well, although I always used to get them confused. Pemphigus vulgaris happens most commonly in middle-aged adults and is a pathology of the desmosomes. So desmoglein 1 and 3 is the autoimmune target. Really common on the mucosal surfaces, so you'll see a lot in the mouth, tongue, possibly genitalia as well, but it's uncommon. The common one is bullous pemphigoid. You will see these patients often elderly patients on the room ward or on kind of gen med wards. And the way to think about it is that it's caused by autoimmune destruction of the hemidesmosomes, which attach skin layers to each other, which is why you get these fluid-filled blisters, because it is literally a space opening up between the two layers. And then you can see the picture at the bottom here. That's exactly what that will look like. It's intensely painful. Interface conditions, you will see a little bit of in questions and possibly not a lot in the actual hospital. Erythema multiforme looks like this and can happen after pretty much any infection. If you look it up, it's a whole load of them that can cause this. Stevens-Johnson syndrome is kind of the precursor to toxic epidermal necrolysis. So when this covers over 30% of the body surface area, you get TEN. That's associated with the drugs beginning with A. So you've got allopurinol, antibiotics, and anticonvulsants. So if you see in a question stem that they've newly started taking an anti-epilepsy drug, then think this one. It's really, really, really bad and an absolute emergency, but luckily very rare. So you'll get a really late onset after the drug and then a flu-like prodrome, and then just suddenly carnage. And that's because you lose the ability to stop water loss through your skin and lose that ability to fight against toxins with that physical barrier. Just really quickly, because I always used to get confused about the meanings of the different erythemas. They all sound the same to me. Probably won't help you if I read them through now, but when you get the slides later, if you get a chance, just make sure to go through, maybe make an Anki deck or something, just stick these in there, make sure you know the difference between them, because nothing more embarrassing than saying the wrong one. Cool. And then the skin conditions that cause that are caused by drug reactions are the fixed drug reaction, which is really easy to remember because every time they take this drug, they will get the exact same rash at the exact same site. Happens 30 minutes to 8 hours after the consumption of a drug, and the same as allergic contact. It's a delayed type 4 hypersensitivity reaction. It can take ages to go away, even if you stop the drug, but you just have to make sure never ever to restart that drug. And then urticaria is the generalized word for itchy. You might have these raised, horrible, angry red wheals, which I'm sure you'll have had if you're someone that's got eczema or hay fever or anything like that. Okay. Infective skin conditions. So the first being impetigo, which is very common in children, especially in kind of nursery age. You get this golden crusting around the mouth and cheeks, typically caused by either Staph aureus or group A strep. So that's strep pyogenes. And you need to isolate the child until antibiotics given, but you probably don't need that for lab med. Amoxicillin treats staph, flucloxacillin treats strep. They both do a bit of each, but if they ask specifically which would you give for a group A strep impetigo, then flucloxacillin is always the better answer. Fluclox is normally the answer for skin infections anyway, to be fair. Folliculitis, very small print, doesn't come up that much. And erysipelas is, think about it as a kind of sliding scale from impetigo to erysipelas to cellulitis. So it's kind of the stage in between. It's a superficial cellulitis, but it's not really got in there yet. Might get it on the cheeks and not sparing of the nasolabial folds. So that's how you know it's not one of those lupus butterfly rashes instead. And again, caused by strep pyogenes. Getting worse, we've got the cellulitis. It's deeper. At this stage, you'll have systemic features of infection, so fever, general malaise, spares the muscle, crucially, and it's really quite rapid. Inflammation of the deep dermis and subcutaneous fat. I've got a list here of the most common organisms, and this you're going to manage as a proper skin infection with high dose flucloxacillin. Next, I'm sure you'll all have heard at some point and been very scared by the idea of necrotizing fasciitis. Um, the thing to think about if you're ever going to think about necrotizing fasciitis is if you ever hear that a patient maybe has a bit of a cut or a shaving rash or like something tiny, or they might have dislocated something and then had it popped back in place. And suddenly they're just in this most excruciating, ridiculous pain. It just seems absurd. They're absolutely screaming over a little cut. That's when you think neck fasc. So you've got this deep infection into the muscle and fascia, especially common if you're diabetic or immunocompromised because you just don't have that same level of protection. Again, most commonly group A strep. I haven't got it here, but can also be Staph aureus. It's just the worst pain and needs immediately to go to theatre. Absolutely theatre instantly, get the antibiotics in and cut, like all of that tissue needs to be cut off if it's been infected. That's not coming back. And then you get this, if you don't respond to antibiotics, you'll get this really horrible Fournier's gangrene, which did actually come up in our lab med. So that's neck fasc of the perineum, and it's really quite nasty to look at. Wouldn't recommend. Okay. Couple of a bit more small print things here. So toxic shock syndrome. Most commonly people have heard of it because if you leave a tampon in for long enough, people are scared, like it's scary, it can cause toxic shock. Other things can also. You get this desquamation, real kind of hypertension and a rash and involvement of a lot of organ systems, similarly to sepsis. It's just really quite nasty quite quickly. SSSS is caused by that horrible exfoliative toxin from 5% of Staph aureus and can be very nasty. And then gangrene is very small print, and that's just where you get this necrosis within the muscle, which causes gas. So then you might end up with compartment syndrome or something like that. And again, you need surgical debridement and antibiotics. Ringworm, called athlete's foot. If it's on the foot, you get these raised red rings. And if it's on the scalp, then it can cause alopecia. Scabies always seems to be around in Oxford, especially in Freshers Week. Causes this real intense itching, especially in the webs of fingers, and you might even be able to see the marks of where the mites have moved through the skin. Managed with permethrin, and need to treat close contacts of the patient as well. So just really quickly, we've got these skin tumours to talk about. So first, we're going to talk about squamous cell carcinoma. And as with a lot of things that we've talked about, it is a bit of a sliding scale. So on the least severe end, you've got this actinic keratosis. It's benign, but can, as I say, become invasive. The word keratosis should make you think scaly. So you've got these scaly, could be macular papules or plaques, really could be anything, sometimes with those keratotic horns. And that'll be present in sun-exposed areas of the skin. So I actually think it's most common on the legs of women and the trunks of men. I'm assuming that's something to do with where people preferentially take their clothes off in the sun. And then if it covers the kind of full layer of the epidermis, then you're dealing with an in situ SCC, sometimes called Bowen's disease. Again, benign with malignant potential. The basement membrane is protective at this stage. It's not been invaded, but you've got full thickness dysplasia. And so, as I've mentioned in a previous lecture, in situ carcinoma is not yet cancer, but absolutely is a precursor to it. So it needs to come out anyway. Invasive SCC is cancer, and that'll have those very classic keratin whorls, intercellular bridges on histology. That definitely has come up in lab med. So if you see those words, think SCC. Yeah. Basal cell carcinoma is different, and that is by far the most common malignant tumor of the skin, presents 50s, 60s kind of age, very low metastatic potential and very slow growing. So while it can be cancer, we actually don't tend to cut it out particularly soon. It will be excised eventually, but there's no kind of 2-week wait pathway for this sort of thing. If you ever see the phrase pearly raised nodules with arborizing telangiectasia, that's a basal cell carcinoma. All sounds like a bunch of words for nothing. If you think about what the words mean, arborizing, so tree-like, these blood vessels kind of branch out like a tree would. It's kind of hard to see on these photos, but just take my word for it, okay? And that wording is pathognomic for BCC. Finally, melanoma, again, a sliding scale. You'll be sick of those by now. So benign nevi, I used to see all the time in the kind of OSCE booklet and be really confused. Nevi literally means mole. Get that in your head now. 3 types depending on the site. Presents between kind of 10 to 25-year-old. People can be born with them. And I'm about to come on to the ABCDE criteria, but it's negative for those. Dysplastic nevi are your kind of equivalent to a carcinoma in situ for the ones I talked about a minute ago. So that's got that metastatic potential, presents adult to teenage often. Some of the ABCDE features, but mostly stable, can go and come back and go and come back, but some do turn into malignant melanoma. And then we've got malignant melanoma. So these are the types of melanoma. I have put them in kind of just for a bit of information if you're interested, but really these don't come up at all. If there's anything you need to know, it's that superficial spreading melanoma is the most common, and the bottom one, I'm not even going to try and say that, is the most severe and worst prognosis. Those are pretty much the only 2 that they would ask you. Assessment of melanoma will come up, and it's really important. So A to E criteria. If the lesion that you're looking at is asymmetric and just not a nice round shape, that's something that gets you worried. If the edges are irregular or blurred, not nicely demarcated, that is also something you want to be worried about. If the lesion has 2 or more colours, it's not just one nice brown colour, that's a worrying feature as well. Diameter of over 6 millimeters is worrying for D. And then E is a bit of a cheat, evolution and elevation. If it's constantly changing, constantly fluctuating, or they took a picture of it a month ago and a picture this month and it just doesn't look the same, or if it's becoming raised, that's also a worrying feature. So melanoma will typically have all of these. Dysplastic nevi will have some of these, and benign nevi will have none of these. They will ask you in either LabMed or AKT how you determine the prognosis of melanoma, and that's with Breslow thickness, which you'll probably have heard of. Thickness meaning downward thickness, so projection into the skin, not thickness as in like amount of skin covered. So less than 1 millimeter thickness is 95 to 100% 5-year survival. But if you've got over 4 millimeters of Breslow thickness, then your 5-year survival decreases significantly. So that's just something to think about. Every millimeter matters. Okay, I've raced really quickly through skin, just because we had some feedback saying that the lectures were maybe a tad too long. So I'm just going to carry on straight into the women's health section. Will be a bit longer, but hopefully will be worth it. So we'll finish about 7:15. And I have got some questions for you at the end to consolidate skin and breast and gynae, just because I often find that doing the questions straight away is really easy, but if you come back to them after half an hour, it's a lot more worth it, I think. So, breast lumps. This is a really helpful little flow chart to get you thinking about when you would start thinking about different differentials. This is just something for you to come back and look at when you have the slides, because this is unlikely to make sense before we've talked about all of these things. Okay, so first we've got fibrocystic change. And for those of you with breasts and periods, you'll know that when you have a menstrual cycle, your breasts change a lot. They can feel different levels of tender and different levels of lumpy and things like that. And that is described by the words fibrocystic change. So it's just cyclic in response to estrogen and progesterone. So you'll get this mastalgia and bilateral lumpy breasts. Crucially, bilateral. If you ever have a patient with just one lumpy breast, then you want to be thinking about something different, probably. And you'd see that on a scan. It would just be more dense breast tissue, nothing to worry about. Another type of benign breast lump is mastitis. So that is inflammation of the breast tissue, just in the word. May or may not include an infection. Important to remember that itis doesn't necessarily mean infection, just might do. Caused by breastfeeding and Staphylococcus aureus infection as a result of breastfeeding, and more importantly, milk stasis. So maybe a couple of days off breastfeeding for whatever reason. You get this unilateral tender lump. I mean, you may get it in both at the same time, but that would be really unlucky. Breast pain, focal erythema, nipple discharge. If you've got an infection, you'd have this fever as well, and it can progress to sepsis if left long enough as an infection, so just be wary of that. For the most part, it's a clinical diagnosis. You can do breast milk microscopy if you were really worried about a really kind of funky organism. But most often, the management, firstly, is to keep breastfeeding. You do not get the women to stop breastfeeding because milk stasis is a risk factor, so you want them to keep breastfeeding as much as they can, maybe pumping or something like that if their baby's not keen on milk. And then after that, you'd be looking at flucloxacillin antibiotics if keeping on breastfeeding hasn't helped. Next, we've got this lovely duct ectasia. So that's periductal inflammation causing the dilation of the ducts, which leads to nipple discharge. And the risk factors for that are smoking and being in the middle of the menopause. So again, bilateral, important to remember, you'll get this really quite nasty, cheesy green nipple discharge. It has a really funny smell. It'll be a well-defined breast lump, as are most benign lumps wherever in the body, and nipple inversion. So if you ever see this really funky discharge with nipple inversion, think duct ectasia. And then, yeah, a biopsy might help, but again, a clinical diagnosis. Fibroadenoma is a really, really common thing, especially in younger women, people of reproductive age, because they regress post-menopause. So there's no association with breast carcinoma, and you'll see this benign fibroepithelial lesion, but it does present similarly to breast carcinoma. So you'll get a lot of people with fibroadenoma in the 2-week wait pathway for breast cancer. And then you might have a biopsy, but some people just have an ultrasound scan or a mammogram, depending on their age, to have a look at what's going on in there. The classic benign breast lump description is smooth, firm, well-defined, and mobile. So you'll get this breast mouse kind of thing where you're doing your examination and chasing it around, and it's just not staying still for you, which is immediately a less worrying sign, because something being tethered to the skin is worrying for cancer. And then on biopsy, you'll get this epithelial and stromal proliferation, and it might just be phrased as biphasic histology. Something that could be benign or malignant is the Phyllades tumor. So it sounds incredibly similar to fibroadenoma, and the real clinical difference is the age of onset. So fibroadenoma in younger women and this in older women. It's a non-epithelial neoplasm of the breast, 50% benign, 25% malignant, and 25% somewhere in the middle. If it were to be malignant, it would be a sarcoma because it's a soft tissue disease. And again, you'll get this smooth, firm, well-defined mobile lump. But if you're seeing it in a postmenopausal woman, that's when you'd want to be a little bit more worried. Fat necrosis has a much more horrible name than it is, actually. It's just caused by trauma to the breast. So whether that's physical, mechanical trauma, particularly common after something that might hit the chest, so a road traffic collision, something like that, or radiotherapy. So if a person has had breast cancer and presented back with a lump, you might be worried about reoccurrence, but could also be this if they had radiotherapy. So it's a benign lump, just caused by scarring, and will present as a non-tender, irregular, non-mobile mass. So that would get you really, really concerned about breast cancer being non-tender, irregular, non-mobile, nipple puckering or inversion. You want to be worried about breast cancer, but fat necrosis is benign. And then on ultrasound or mammogram, it can look similar to cancer, but you'll see these foamy macrophages and just general damage instead of dysplasia. Again, on the scarring vein, it'll be another differential is the radial scar. So that'll have a central nidus of proliferating, entrapped, kind of a bit of a mess, to be honest. Very small chance of conversion to carcinoma, but that won't come up. It'll often be asymptomatic and picked up incidentally as a star-shaped mass on a mammogram. Can look similar to cancer on mammogram, but yeah, you'll see these scar formations again. Intraductal papilloma is something that, again, you want to be worried about breast carcinoma. It is a benign intraductal proliferation and causes this unilateral. So just something to really hammer home is that bilateral things are often caused by things that are not breast related. So hormonal changes, things like that. Whereas unilateral is a lot more likely to be localized to the breast. Unilateral bloody nipple discharge and a lump. And you'll see epithelial and myoepithelial proliferation around a fibrovascular core. And it's that phrasing that is the only time I've ever really seen this come up in a question. Yeah, so just bear in mind the wording of that one. Ductal carcinoma in situ, as I've said before, is not cancer, but can very easily become cancer. So this ductal columnar cell hyperplasia has not yet invaded the basement membrane, but does have the potential to spread locally and has a 30% 10-year risk of progression to carcinoma. So it doesn't really matter whether it's cancer or not, you just need to cut it out. Probably non-palpable, asymptomatic, might come with Paget's disease of the nipple. So just as a side note, I'm not sure if I've got a slide on this. Paget's disease of the nipple, which you'll hopefully have already covered, is it essentially looks like eczema of the nipple, but isn't eczema of the nipple. It responds to different treatment and won't respond to steroids in the same way. And then once the basement membrane has been breached, that's when we've got malignancy on our hands. So that's invasive breast carcinoma. Most commonly ductal, so within the ducts, can be lobular. Inflammatory is very rare, but is the worst prognosis. You always want to check in a patient, particularly in your OSCE, you always want to check the armpits for lumps there because axillary lymph node spread is really, really common. And then the most common sites of metastasis are the lung, liver, bone, and brain. So you always want to be checking for signs of metastasis to there as well. And you'll get the classic malignant, painless, hard, irregular, tethered breast lump with nipple deformity and discharge, skin puckering, perhaps a peau d'orange appearance, and, as I said before, axillary lymphadenopathy. So for that, you'll want to get a scan. Ultrasound is most likely to be useful in women under 30, and that's because they have more dense breast tissue. And as you get older, it becomes less dense, and a mammogram becomes more helpful. You'll want a core biopsy and axillary lymph node fine needle aspiration with genetic testing, especially if the patient is relatively young, because that makes it more likely that they have a cancer disorder of some description or a BRCA mutation. So you want to do that for the patient and their close relatives, and get genetic testing of the tumor as well to know how to manage it. But that will come up more in the AKT. Yeah. Okay. So I've just talked about BRCA. Being estrogen receptor positive means that it can be targeted with tamoxifen, which is a good drug. And then being HER2 positive means it can be targeted with the Herceptin monoclonal antibody. And as I've just mentioned, Paget's disease of the nipple will be described like eczema, but will not respond to eczema treatment. It is the spread of ductal carcinoma in situ through the ductal system to directly involve the epidermis of the nipple. So that's something you want to be worried about, and you want to go in further to investigate for that DCIS. It'll give you this unilateral eczematous rash and bleeding. A couple of extra bits. Benign cysts can happen, galactoceles can happen, both quite small print. In an OSCE or occasionally in LabMed and AKT, they will ask you what is the most appropriate next step after a person presents with a breast lump. And the answer is always, always, always triple assessment. So that is a clinical assessment, so a physical touching the lump examination, a scan, which I've talked about before, varies depending on age, and biopsy. Always those three things. And then the UK screening programme, LabMed, as you'll know, sometimes asks questions about what different screening programmes look like, and so does the AKT. So just get this in your head, and then any further familial history. Okay, so we're making good time. Yeah, as always, if anyone has any questions or anything, then please do stop me. I can't see the chat at the moment, but please do speak up. Finally, we've got gynae, and that's one that I'd like to spend some time on because I really don't think it was covered to the level that questions were asked last year. So I've arranged it slightly differently to previous years. So I've arranged it based on the organ affected and whether that pathology is benign or malignant. So within the uterus, we've got a lot of potential benign pathologies, which we will come on to in detail. And then, as always, malignant as well. Yeah. I found in questions last year that I really didn't understand the terminology that was being used, and was always just kind of making it up, especially as sometimes they'll be a bit cheeky and put, oh, a woman is presented with 3 months of IMB, and not tell you what that means. So I just thought this would be helpful. Yeah, this is just something you can go through by yourselves. So the first benign uterine condition is endometritis, and that is, as it says, literally just inflammation of the endometrium. Acute will be caused by the cervical os being open and a bacterial infection coming on up through. So that could be after the delivery of a child or after a miscarriage. And then chronic endometritis is seen in pelvic inflammatory disease, which we will come on to later. It just presents as any infection would: abnormal vaginal bleeding, infertility, pelvic pain, fever, the classic. It always wants to be a differential on your list with any of those symptoms. It's super, super common after delivery. Endometrial polyps are benign overgrowths of the endothelium. They don't just have to be endometrial, they can be cervical or vaginal as well. They'll present with abnormal uterine bleeding, and for that reason can mimic endometrial cancer. So that's a differential you want to think about. The reason that they bleed is often because of trauma, so literal shearing forces. They can just bleed on their own, but you do want to think about bleeding during periods because of the hormones, and also bleeding after sex. So that's postcoital bleeding. Investigation with transvaginal ultrasound and possibly a biopsy if you're worried. Adenomyosis, I used to find confusing until it was explained to me as essentially endometriosis, but with the invasion of the endometrium going inwards instead of outwards. So it's remaining within the uterus, it's just the endometrium invading into the myometrium. So you've got those glands, hence the word adeno, invading the myometrium. And that's most common after having multiple children, so multiparity. Clinically, you'll have really, really similar symptoms to endometriosis, which I'll come on to next. Menorrhagia, so heavy periods, significant pain with periods, so dysmenorrhea, bulky, tender uterus, and deep dyspareunia. So dyspareunia is pain during sex. If it's deep, then that's that real feeling within the abdomen. And if it's superficial, then it is literally more superficial. So more kind of skin, vaginal opening related. Yeah, so it was described to me as essentially the symptoms of endometriosis, but with extra heavy bleeding. And that's because of the gland invasion of the myometrium. Whereas endometriosis has all of these symptoms with quite irregular periods, but doesn't necessarily have heavy periods, so that menorrhagia. Investigations, you'll want to do a bimanual exam. So that's something that you'll learn to do in 5th year on the volunteers. That's a 2-finger insertion into the vagina and using your other hand to feel the kind of bulky, tender uterus. Transvaginal ultrasound, and then biopsy as well. So next is endometriosis. This is the presence of endometrial tissue which still responds to menstrual hormones outside of the uterus. So it can move to the fallopian tubes, ovaries, uterine ligaments, can cause bowel obstruction if it gets to the rectum, causes adhesions, pains, infertility due to ovarian stricture, and can even get up there and cause pneumothorax if it gets into the chest cavity. A good sign to look out for in a question stem is the phrase retroverted uterus. So normally a uterus is anteverted, so kind of flopped over towards the front of the body. If it's kind of standing up tall, so retroverted, then think endometriosis, because it could be that a stricture and adhesion is causing it to have to be pulled backwards. Clinically, chronic pelvic pain, dysmenorrhea, deep dyspareunia, which will be cyclical, so worse at certain times of the menstrual cycle, and irregular bleeding. Transvaginal ultrasound is good, but can't necessarily rule out a diagnosis because there are like big skip periods in between lesions. Diagnostic laparoscopy, so going in and having a look, is the gold standard. The phrase leiomyoma got thrown around a lot last year, and it took me a while to realize that those were just fibroids. So you'll get these benign smooth muscle tumors of the myometrium. The word benign is a tricky one because obviously it's not cancer, but benign, I feel, almost implies that it's all right, you'll be fine, when actually these can just be such a nightmare for patients. So they are growth sensitive to progesterone and estrogen. They can be in a variety of places, so subserosal, intramural, submucosal, so it can be in the walls, poking out the walls, in the uterus, in the abdomen, anywhere. Complications include iron deficiency anemia from the sheer amount of bleeding that these people do on their periods. Red degeneration of fibroids is a really serious complication which can happen when the vascular supply is cut off and there's necrosis, and it can all just get nasty and turn to sepsis very quickly. Symptoms of mass effect, so that's the fibroids pressing on other structures within the abdomen and causing issues, could cause ovarian torsion and rarely can progress to leiomyosarcoma. Clinically, you'll get very heavy periods, abdominal and pelvic pain, pressure effects, and deep pain during sex. And ultrasound is very, very effective for guiding treatment. On biopsy, you would see these whorled white surfaces with bland spindle-shaped cells, but I didn't actually see that phrasing come up last year. Endometrial hyperplasia is not inherently malignant, but can progress. It's this exaggerated endometrial glandular proliferation, which is caused by prolonged estrogen exposure unopposed by progesterone. So risk factors for that are having had menarche at an early age, so having started your period at 8 as opposed to at 14. So that's obviously 6 extra years of estrogen exposure. Late menopause for the same reason. Nulliparity, so that means never having been pregnant, had a child, which again sounds like a funny one, but that is literally because they've had more periods because their periods weren't stopped by having a child in their uterus. So yeah, those are all the things that cause estrogen exposure unopposed by progesterone. Same with if you were to give hormone replacement therapy to a person who is perimenopausal, and if you were, so estrogen helps the symptoms and you give progesterone specifically to avoid it being unopposed by progesterone and therefore increasing the likelihood of endometrial hyperplasia. Clinically, you'll get this abnormal uterine bleeding and transvaginal ultrasound, hysteroscopy, so having a look in there with a camera, and biopsy are important. As I said, it can progress to cancer. Another benign uterine condition is the hydatiform mole, so also known as a molar pregnancy, and it's just where the pregnancy-associated trophoblastic tissue goes all wrong, all pear-shaped. A complete mole is where 2 sperm essentially attempt to fertilize one another and form a child. So that is a completely unviable fertilization right from the get-go. So a complete mole, as I said, and on ultrasound, you sometimes see the words in questions, snowstorm appearance. I actually don't really know what that means, but just remember that. The partial mole is where 2 sperm at the same time fertilize 1 egg. And these are the risk factors. So having had it previously, extreme maternal age, and being of Asian ethnic origin. Clinically presenting with vaginal bleeding, missed or incomplete miscarriage. And you'll see on investigation in a complete mole, the classic phrase is grape-like chorionic villi. Yeah, if you want to look that up, do, because I think it makes more sense when you see it. And a partial mole is a kind of subtle histological abnormality. It's a lot harder to spot. And then malignant uterine is endometrial cancer, caused by the progression of that endometrial hyperplasia I talked about to adenocarcinoma. Sorry, that's my housemate. So endometrioid carcinoma is the most common. That is estrogen dependent, as is again massively increased in risk by longer periods of increased estrogen exposure with no progesterone to moderate that. Serous and clear cell carcinoma and carcinosarcoma are very rare. Clinically, you'll have this abnormal uterine bleeding again, And you want to especially be worried about this in women who have supposedly undergone the menopause or been on HRT for over 6 months, because they should not be bleeding by this point. As you can imagine, in younger women, it's a lot harder to differentiate from periods, but in that case, you'd have really, really heavy ones, or bleeding between periods, or again, bleeding after the menopause. Yeah. And this is what biopsy shows. So within the cervix, we'll move to the cervix now. One common benign pathology is pelvic inflammatory disease. And the pathophysiology of that is inflammation and infection of the pelvic organs because of an ascending infection from the endocervix. So most commonly, sexually transmitted infection that has gone untreated and has literally marched up the organ and started causing issues elsewhere, and then becomes a lot harder to treat. It also could well go unnoticed for a while. It can be completely asymptomatic until it's really quite bad, most commonly caused by untreated chlamydia. So with that, risk factors are things that would be more likely to cause untreated chlamydia. Complications can be really nasty, so sepsis, abscess. Fitzhugh-Curtis syndrome comes up occasionally because it's a really nice question. So if you see in a question a history which possibly says that a person might be more likely to have an STI, and with that, left upper quadrant pain, then that's Fitzhugh-Curtis syndrome, because the bacteria have ascended to the liver capsule and caused liver capsule inflammation. Chronic pelvic pain and ectopic pregnancy are also complications. You'll have this pelvic or lower abdominal pain, deep pain during sex, abnormal discharge or vaginal bleeding, and fever as an infective symptom. So for that, you'll want an STI swab to look for the infective organism, and an ultrasound scan to rule out any complications. Cervicitis, same as endometritis, is just an inflammation of the organ. Can again be acute or chronic, and is most commonly caused by an STI. And then malignant cervical carcinoma comes up a lot in exams, and I'm sure you'll have covered it within your lab med course. So it's cervical malignancy preceded by cervical neoplasia, so CIN. Most often causes squamous cell carcinoma, but in 5 to 10% can cause adenocarcinoma. Risk factors for that, as I said earlier, are exposures to strains 16 and 18 of HPV, which means that a risk factor for having this is never having been vaccinated against HPV. Other things that increase your risk of exposure are on early onset of sexual activity, anything that might increase your risk of picking up this virus. Immunosuppression, smoking is a big one, and long-term use of the combined oral contraceptive pill. Clinically, they'll come in with abnormal vaginal discharge or bleeding. You want to put them straight on the 2-week wait for unexplained postmenopausal bleeding, if that's what they've come in with, unexplained and persistent discharge. And on a smear test, which is really important, you want to check if this person is up to date with their smear tests. And in a lab med question, they very often won't be up to date with their smear tests. You'll see this CIN that will have been talked about in lab med. Investigations, you want colposcopy, and biopsy. Just a quick note on what I was saying just there. So the cervical screening and vaccination programs are really important prophylaxis for these conditions. At the top there, you can see how HPV 16 and 18 work, but that's irrelevant for exams, just a bit of information. And then the vaccination program now covers boys and girls, although didn't when we were at school, I don't think. Pap smear every 3 years for the 25 to 49-year-old age group, and every 5 years after that. It tests for HPV, and if the person is HPV positive, then their cytology is examined. And if in a question you see that cytology showed dyskaryosis, then that is CIN, and you want to be worried about progression to cervical carcinoma. And with that, you want to cut out all of the CIN. Moving on to the ovaries and tubes. Salpingitis, again, just inflammation of the organ, can be acute or chronic, most often caused by STIs, but can also be iatrogenic. So like insertion of different contraceptive methods, surgery, things like that. Complications include pyosalpinx, so that's pus within the tubes, hydrosalpinx, so that's fluid within the tubes, adhesions, infertility because the eggs can't travel out of the tubes, and ectopic pregnancy because they become stuck in the tubes. Clinically, unusual vaginal discharge, a variety of different pains, dyspareunia and dysmenorrhea, and you want to investigate that with STI swabs and possibly an ultrasound. Follicular cysts, you'll hopefully all have heard of ovarian cysts before, and that involves the failure of a follicle to rupture and release the mature egg during ovulation. A real big complication that you want to think of is ovarian torsion, because the cyst provides a focal point for this turning and then makes it really hard for it to turn back again. So you'll get this dull, aching pelvic pain. Should self-resolve in 6 to 8 weeks. They often do, but you do want to repeat the ultrasound after that time, because if it doesn't, then you need to be thinking about surgical management. Again, within the ovaries, ovarian epithelial tumours might be benign, might be malignant, 80% benign. The most common is benign serous cystadenoma. So if a question asks which is most likely, then it's that. Sorry, I don't know why I've put. The second one isn't supposed to say most common. Oh, sorry, yes, it is. It's because it's the most common ovarian malignancy, not the. So the top one is the most common tumor, and the second one is the most common malignancy. Sorry about that confusion. Risk factors are BRCA mutations, older age, increased number of ovulations. So again, it's that early menarche, late menopause, never having been pregnant. Smoking, obesity, asbestos. Smoking and obesity are always good bets for risk factors for cancer. Clinically, bloating is a big one. Anorexia. Just as a side note, it's really important to remember that anorexia as a symptom is not anorexia nervosa, the eating disorder. It is literally just being unwilling to eat, not having an appetite. And that's because you've got this big mass in your stomach, in your abdomen. Pelvic pain, urinary symptoms, systemic symptoms. And something that will come up is the CA125 tumor marker as the marker for either the existence or progression of ovarian cancer. It's pretty non-specific, but as with PSA in prostate cancer, is good for monitoring progression. Ovarian germ cell tumours are quite similar, can be benign. So, for example, dermoid cysts, and can be malignant. So the immature cystic teratoma is malignant, and that's the one that comes up quite often in like medical dramas and stuff, where the cyst is a bag full of hair, teeth, pus. If you've seen one taken out in surgery, it's quite an interesting experience. So because it's a teratoma, the stem cells are very, very, very undifferentiated, so can just cause absolutely any tissue to grow inside that cyst. Often asymptomatic until you get symptoms of mass effect within the pelvis. LDH is a tumor marker for that one, but again, very non-specific. Malignant ovarian is ovarian sex cord tumors, and the pathophysiology for that is most often granulosa cell, which secrete estrogen. So it can actually be a double whammy of then causing endometrial cancer because of unopposed estrogen. And then the rest don't really come up in questions, but good to know. Same clinical presentation as the symptoms of mass effect from the other ovarian tumours. AFP is a good tumour marker, and beta HCG is something that you want to check, just to check that they're not pregnant, but can also be used as a tumour marker. And then finally, we'll move on to the vulva. Benign, it's actually quite common to have a Bartholin cyst. So that happens secondary to obstruction of the Bartholin gland, which can cause infection. And the Bartholin gland is what lubricates the vulva. And just getting that obstructed means the formation of this lump that you can see down here. It'll be soft and painless until it's infected, at which point it will be tender. Lichen sclerosis, there are other types of lichen as well, so lichen simplex and lichen planus, but this is the important one to know for lab med, because it's quite easy for them to talk about on histology. So you'll get this epidermal atrophy and subepithelial fibrosis, unclear pathogenesis, and presents in middle-aged women, so 45 to 60. In a question stem, it will tell you that the skin is really, really weirdly white, like very bright white. Labial atrophy, which you should note is common anyway in postmenopausal women. Pruritus of the vulva, so real intense itching, which, as I said before, itching any skin pathology makes it worse. And superficial pain during sex. And then malignant vulval, as with most of the things in this lecture, you've got the precursor, in this case, vulval intraepithelial neoplasia, VIN, goes on to then cause, in 85% of people, squamous cell carcinoma, and in 15% of people, in 15% of cases, something else. Doesn't always necessarily develop, but it's important to excise it when you do notice it. Risk factors, again, are HPV infection, inflammatory skin conditions such as eczema of the vulva or lichen sclerosis, smoking, etc. Clinically, we'll present with a vulval lump, which is commonly ulcerated and itching, or unexplained vulval bleeding, and you want to get them on the 2-week wait for that. Investigations are a punch biopsy or a wide local excision, and with an SCC, again, you'd see that keratin. Oh, I've got the QR code here, but I'll actually do the questions first, and then we'll come back to that if that's okay. So I've got four skin questions and then 4 breast and gynae questions. And then, yeah. So this is the first one. Have a look at it, write down your answer, and then we'll talk through the answer in a second. I'm not doing the VVox stuff just so that you have this, have these questions available to you for your revision within the slides. Okay, so hopefully you've had a read and realised that this is an allergic contact dermatitis to nickel, and that the gold standard investigation for that is the skin patch test. The reason for that, if we were to go through them, is that, as we've said, it's allergic contact. So this is not an allergen that's making it within the body, it's just on the skin. So the skin prick test wouldn't necessarily replicate the conditions of that allergy the best, because it involves going a layer deeper. The skin patch test, as I've said, is the right answer. It involves longer exposure and exposure in the right place on the outside of the skin. Skin biopsy isn't necessary at this stage. If the issue were to carry on, then maybe you'd want to think about cancer, but that's not for cancer. Serum IgE, you do want to think about in type 1 hypersensitivity reactions. So allergies to foods, anaphylaxis to things like that, but not necessary for allergic contact dermatitis. And then serum nickel antibodies, I don't even know if that's a thing. Okay, the second one, have a look at the image and decide what you think that is and what the most likely diagnosis is. Okay. The most likely diagnosis for this one is plaque psoriasis. So well done if you said that. The reason for that is that hopefully you can see that this is the outside of an elbow, so an extensor surface, which should automatically get you thinking of psoriasis. Hopefully you can see the plaque formation. It can be kind of hard to see, but if you can see the white bits, then that should get you thinking silver scales. Atopic eczema could still be that, but less likely given the fact that it's on an extensor surface and has those plaques forming, which just isn't quite right for eczema. Bowen's disease, as we've already talked about, is SCC in situ, which is not right for this. This is far too large and doesn't look like an SCC at all. Flexural psoriasis, it's an extensor surface, so not that. And then tinea corporis is most common on the scalp and causes alopecia. So, next skin one, have a read of the history and have a look at the picture. Okay, hopefully you've had a read and thought that this is urticaria, in which case you would be right. Let's go through why it's not the rest of them. So first, angioedema. You would be right in thinking that it could be. Angioedema is a common symptom of allergic reactions. It's significantly more common in anaphylactic allergic reactions, and he's saying he feels well and doesn't have any other symptoms, and he's brought himself to his GP. So this isn't anaphylaxis. Angioedema is also a lot more regular shaped. So you'd see angioedema of the lips and tongue, for example, of which all of them are swollen. It wouldn't just be lumpy bumpy. Atopic dermatitis, we don't have a history of anything new touching his back. Oh, sorry, I've read that wrong. Atopic dermatitis, it's not eczema just by looking at it. It's new in a 45-year-old male, which would be very rare. Although he does have a history of asthma, so you'd be right to have a think about that. But it just doesn't look like it. It doesn't have the history of it. And it's raised, which should be an important giveaway. Hanoxian-Lyme purpura, hopefully you'll remember, is a microvasculitis that is most common in children and has a rash that doesn't look like that, basically. And then urticaria is what this is. It's raised itchy wheals that are a response to something that the body's reacting to. It's so non-specific. The fact that he's a gardener, I think they're wanting us to think about contact with new plants that could be making him itch, but yeah. And then the last skin one, Hopefully, I've drilled this into you. If you said depth of melanoma, you'd be right. That is, they deliberately haven't used the word so that you don't just see it and click, but that is Breslow thickness. Um, the depth of melanoma is Breslow thickness, and that is the single most important prognostic marker. The answer never changes and it always comes up, so just learn that. You'd be right in thinking that all of the rest of these are also risk factors, but are risk factors, but the single most important prognostic marker is the depth. Okay. So now we've got a breast history and a question. Okay. Hopefully you've had a read of this and remembered what I was trying to badge you about earlier, which is Paget's disease of the nipple. It's a really, really common answer in questions, comes up all the time with pretty much this exact history. So they have actually been a bit cheeky and told you about a history of allergies as a child, including hay fever, which might get you thinking about eczema. But a couple of crucial things that differentiate this are the unilaterality of it. Only being on the right nipple is weird. You can just get eczema on one side, but why would it just suddenly appear on the right nipple aged 50? They've tried treatment for eczema, tried hydrocortisone cream with no improvement. And then you've got this red scaly thickening of the nipple. Um, yeah, so for this, you want to be thinking Paget's disease of the nipple, and you want to be investigating for underlying ductal carcinoma in situ. But yeah, Paget's disease, I should say that Paget's disease of the nipple can also arise from other things. It's a bit more small print, but there are certain drugs that can set it off and things like that. So it doesn't necessarily need to be tied to DCIS. Next breast question. And then while you think about it as well, just make sure you know what all of those words mean and you can remember. So the answer to this one, the most likely diagnosis is mastitis. As soon as you read that they gave birth 2 weeks ago and now have breast pain, you want to be thinking about mastitis. The fact that it's warm and swollen and erythematous, so red, you want to be thinking about infection. That should hopefully be second nature by now. Mastitis and breast abscess are the only two there that involve infection. So hopefully you remember that fibroadenoma is the breast mouse, the kind of lump that arises in younger women. DCIS we've just talked about, and fibrocystic change is that menstrual cycle change. Mastitis is from milk stasis and is just inflammation as a result of that. And breast abscess can occur as a result of mastitis, but this is only a 2-day history of pain, so we have no reason to jump to 5 before 4. Okay, now we've just got 2 gynae ones. Okay. Hopefully, you've read this and remembered the retroverted uterus thing being a bit of a flag for endometriosis. And for that, you would be right. Um, these symptoms are obviously a bit non-specific. Um, chlamydia and pelvic inflammatory disease. I think for this, you can rule both of them out. We don't have any sort of sexual history to go off of, but I think there are more likely things you want to think about first. Um, uh, okay. Um, ectopic pregnancy is a surgical emergency, and she's presented to her GP. Um, and ovarian cyst would be another differential, but wouldn't cause the bleeding. And then this is the last one. So hopefully you've remembered that there were definitely a couple of tumor markers that I mentioned. Hopefully you've remembered that CA125 is the best and most specific ovarian tumor marker. It's not necessary, it's not perfect and is still non-specific, as I said, but the only other one on this list that I've mentioned today is AFP, which is considerably less specific because it can also be involved in liver tumors as well. Just to go through these very quickly. So just so that you're aware, this history is very, very classic for ovarian tumor, the classic mass effects that I talked about before, and the loss of appetite being anorexia. Mother, grandmother, and sister all having breast cancer is a real flag for a BRCA mutation within a family. So that causes breast and ovarian cancer. So you want to be thinking about ovarian cancer in this instance. CA125 is the marker for that. Just for a little bit of extra detail, these things will all come up throughout the year. CA199 is for pancreatic cancer, AFP mostly to do with livers. HER2 is, I talked before about that being sometimes a receptor that's present on breast tumors, and CEA is for colorectal cancer. Yeah. So that's all of the questions. I'll go back to the QR code and thank you very much for coming. If you want the slides, please fill in the feedback. And I hope your exam goes well. Good luck. Okay, sorry, you're right. I've just read the chat and realized that you do need permission. I will change the permissions on there and get that sorted right away.